Hi, my name is Jonathan Scrafford. I'm an obstetrician gynecologist with Ascension Health in Wichita, Kansas. Together, we can help medicine thrive. I'd like to spend a few minutes addressing the important and challenging task of navigating clinical rotations as a Catholic medical student. In particular, I'm going to focus on clinical rotations that deal with contraception, and we'll touch on concepts like cooperation with evil and the principle of double effect. Cooperation with evil refers to the free and knowing assistance of one individual in an immoral act performed by another individual. The summary I give in the next few minutes is a little simplified, but it highlights the key principles. Most notably, I'll point out that the immediate material cooperation with evil is the part that most commonly is encountered on clinical rotations. First, though, cooperation with evil is typically separated into formal or material. Formal cooperation refers to that in which the cooperator actually wills the object of the act, wills the act to be done. Either considered explicit, if they want the act to be done for the same evil purpose as the agent, or implicit, if they want the act to be done but perhaps for a different purpose. In either case, if they truly wish that the object of the act is done, then this is considered illicit and wrong, inasmuch as the act is wrong. For each of these, I'll give an example outside of medicine and one within medicine. In the case of formal cooperation with evil, one example of this would be like a getaway driver in a bank heist. They want the heist to happen, perhaps for different reasons. In the medical world, this would be like prescribing a medication or placing a referral, basically acknowledging that they are not doing the act itself, either taking the medication or the surgery, but that they support it by prescribing it or referring for it. On the other hand, material cooperation refers to that in which an act is cooperated with only as a matter of circumstance, but the cooperator doesn't necessarily intend that the object of the act itself happen. This is further broken up into immediate or mediate. Immediate cooperation with evil is one in which one's contribution is so intimately linked to the act that they're nearly indistinguishable. Outside of medicine, this would be, for example, like a bank employee who helps open the vault and load up the money for the individuals in the heist. Now, if this is done willingly, of course, this would be illicit or wrong. But even this type of cooperation could occasionally be justified if it's done under duress. For example, if a security guard were held at gunpoint and told to cooperate. In the medical world, this would be like assisting with the surgery. Even if you're not doing the most critical steps of the surgery or the procedure itself, assisting basically indicates that you're offering such a high degree of cooperation and assistance that you're held responsible. On the other hand, mediate cooperation is one in which one's contribution to an act is physically and materially related, but is separated causally from the act itself. This can be either proximate, in which case there's very little causal separation. For example, if a bank employee gave the blueprints or the security schedule to the heist folks, or in the case of like a pharmacist dispensing a medication. In these cases, the degree of cooperation is considered fairly close to the action, not completely the action itself, but fairly close to it. Or it can be considered remote, in which case there's a fair degree of separation. This would be, for example, the mechanic who services the vehicle for the getaway vehicle. Even if he's unaware, he is providing some degree of material cooperation that in the end helps the act happen, but it's so far separated and his knowledge may be either absent or so mitigated that he doesn't hold responsibility. In the medical world, this would be, for example, a janitor who helps clean an operating room or a healthcare facility where abortions or sterilizations are done. Ultimately, this type of cooperation can be justified or unjustified depending on the proportionate good reason for which they're being done, the degree of causal separation, the reasonableness of other alternatives, prudential judgment, as well as the potential for scandal. The principle of double effect is the other principle I wanted to outline. I won't spend quite as much time on it, but this is basically a principle describing the conditions under which an action pursued for a good reason could be permissible even though it has anticipated negative consequences. The first condition of this is the nature of the act, meaning the act itself has to be either morally good or morally neutral. So this does not apply to intrinsically evil acts. The second condition is intentionality, meaning that only the good outcome of the act is intended. The third condition is the means-end condition, meaning that the bad effect must not be the means by which the good effect is achieved. And proportionality refers to the concept that the good outcome must be proportionate to the anticipated bad outcome. So the general idea behind this principle is that an action may have two independent effects, not one that leads to the other, but two independent effects, one of which is good, one of which is bad, and that it could still be legitimately performed for the sake of the good action, even if the negative action is anticipated and not preventable. Some examples in clinical rotations would be surgical treatment of a ruptured ectopic pregnancy, understanding that removing a fallopian tube would have the consequence of the baby dying potentially, if it hasn't died already. I mean, and but also has the good effect of trying to save the mother's life. Another example would be surgical or medical management of abnormal uterine bleeding, or even pain management in the end of life. I'd encourage you to read a little bit more about this principle of double effect because it does come up fairly often in clinical rotations. I'll spend the last couple minutes here talking about clinical rotations. Some general concepts. I'd recommend avoiding the refusal of any of care for a patient altogether. You may refuse to do certain interventions that people may want you to do, but I would avoid ever refusing to care for a patient altogether. I'd also avoid any formal cooperation with evil, try to reduce as much as possible any material cooperation with evil. Participate as much as you can to learn, as long as it can be morally justified. And as much as possible, if you're going to have discussions about not participating in certain interventions, try to do it one-on-one and in advance. Finally, make sure you examine your conscience frequently, and if you do make a mistake, take it to confession. At the end here, we'll talk about a few clinical dilemmas. So one would be co-signing birth control to an attending in clinic. You know, if you're working with an attending and they want you to be writing their prescriptions as you're going through. Some things you could do here, I would recommend notifying your supervisors in advance if you have an ethical objection to co-signing birth control. Offer to counsel the patient, and then offer to educate or refer for fertility awareness-based methods. Scrubbing into a C-section. This often happens on clinical rotations. You might know that the patient's getting a tubal with their C-section. You could refuse to scrub in if you feel that scrubbing in at all is a too high a degree of cooperation with evil. You could scrub in but only observe if you feel that that's going to garner you more education but not morally implicate you. And you could even scrub in and assist with the C-section part, but make it clear to the team that during the portion that's the tubal that you won't be participating in that part. Similarly, assisting with a self-injectomy for a ruptured ectopic, you could refuse to scrub in if you don't feel that you could square it with your conscience to participate under the principle of double effect. You could scrub in but only observe, or you could scrub in and assist under the principle of double effect in this case. Counseling a patient with an unintended pregnancy, finally. Always offer to counsel, offer to give information about pregnancy resource centers, and then again, most important, if you anticipate that someone's going to be asking you to refer for an abortion, make sure to let them know ahead of time of an ethical objection to that. This is my email address. Thank you so much for watching. I hope this brief introduction to the concepts of cooperation with evil and the principle of double effect will assist you as you navigate the dilemmas that occasionally arise during rotations. I confidently hope that the Holy Spirit will offer you all guidance and wisdom in your professional development. Please don't hesitate to contact me if you would ever want to run a scenario or a question by a Catholic OBGYN. God bless you all.